ectopia lentis is the displacement or malposition of the crystalline lens from its normal position in the eye, resulting in varied manifestations. It occurs in microspirophakias as seen here with anterior dislocation of the lens. Syndromes like Marfan's with increased arm span, high arched palate, aracanodactyly etc. after trauma or merely as idiopathic. Conservative management is optical correction with glasses correcting either the phakic or aphakic pupillary axis, but the outcome is unsatisfactory and non-physiological as evidenced here. Indications for lensectomy are poor vision due to either lenticular astigmatism, anisometropia, lens edge bisecting the visual axis or cataract, or secondary glaucoma due to recurrent attacks of pupillary block, or finally dislocation which is either impending or there is already existing anterior dislocation with endothelial touch or a posterior dislocation. Surgical management is the removal of this lens by aspiration followed by capsular bag fixation and implantation of posterior chamber intraocular lens in the bag or other alternatives as shown. An alternative is lensectomy using modern automated vitreous cutting devices that is relatively safe and successful. Ectopic lenses are like sinking ships. Operating on such a lens with phacodonosis with lax zonules that is seen in most of these cases, it is like maneuvering a ship caught in a storm. Either way, it may sink. This video demonstrates the various techniques of performing lensectomy and anterior vitrectomy in pediatric ectopia lentis in a stepwise manner. Superior rectus bridle suture is taken, limbal side port incision is made at 2 o'clock and the anterior chamber is formed with high molecular weight viscoelastic to stabilize the anterior lens surface during lensectomy. Lensectomy is initiated using the vitrector and the infusion starting from the edge of the lens. Moderate cut rate and relatively high vacuum is used to ensure good aspiration and prevent posterior migration of lens material. Anterior vitrectomy is done. Any vitreous prolapse at the wound is removed. Iris repositor is used to sweep across the anterior chamber and check for completeness of anterior vitrectomy. Anterior vitrectomy is done thereafter with high cut rate and low vacuum. Indirect ophthalmoscopy can be used intraoperatively for fundus examination to look for any lens material drop. Intracameral pilocarpine is instilled to constrict the pupil. Anterior chamber is washed and side ports are hydrated. Post-operatively, there was a good improvement in vision with only mild hyperopic correction. In this 6-year-old boy, lensectomy is performed through limbal approach again using 2 side ports. A closed system endosurgical technique allows the anterior chamber to be maintained, preserves normal anatomical relations and prevents scleral and vitreous collapse. Here we demonstrate the use of a cotton bud to indent the sclera. This helps visualize any capsular or cortical remnant and to complete the lensectomy. This child too had significant improvement in visual acuity with moderate hyperopia. In this 5-year-old child, there was nasal subluxation of the lens, and note the absence of zonule seen temporally. In this case too, lensectomy is initiated through a limbal approach via 2 side ports. After making an opening into the capsule using the myringotomy blade. Lensectomy is performed with the cutter for the area that is visualized in the visual axis. For the portion of the lens that is behind the iris, the second instrument is used, that is the irrigating cannula, to retract the iris and visualize the contents. Thereafter, the same cutter is used, but now only in the aspiration mode with the cutting mode off, so as to remove the lenticular material under direct visualization, as can be seen here. Post-operatively, there was significant improvement in the vision as compared to the pre-operative levels. In this 5-year-old, Lensectomy is done through the limbal approach but with a modification. Continuous curvilinear capsulorhexis is done with microrhexis forceps after making a nick in the anterior capsule. Hydrodissection is then followed. Bimanual lens aspiration is then done using irrigation and aspiration. The same cutter is used, but now only in the aspiration mode with the cutting mode off so as to remove the lenticular material, as can be seen here. Followed by capsulectomy, that is removal of the bag with the cutter, and anterior vitrectomy with the vitrector. This technique ensures complete cortical removal and also any drop of the lenticular material posteriorly. Post-operatively, the vision has significantly improved as compared to the pre-operative vision. In this child who underwent lensectomy with anterior vitrectomy through the limbal approach, 2 iris hooks are placed to retract the iris on the subluxated side for better visualization. Due to the subluxation, you need not put 4 hooks and 2 suffice, especially if put on the area of subluxation. By introducing instruments through the same ports as the iris hooks, it avoids unnecessarily and more corneal side ports. Post-operatively, there was significant improvement in the vision as compared to the pre-operative levels. This case presented with spheriophakia, with subluxation and high myopia, and had poor mydriasis with shallow anterior chamber. We begin with placing 4 iris hooks to dilate the pupil. Anterior capsulotomy is done using cystitome along with microrhexis forceps for the capsulorhexis. Hydrodissection is then performed. Bimanual lens aspiration is done. Thereafter, capsulectomy is done with vitrector followed by anterior vitrectomy. The entire bag is then eaten up with the cutter. Endoilluminator is used to check for any lenticular or capsular remnants. The main aspect of this technique is total aspiration of the lenticular material within the capsular bag, which prevents any migration into the vitreous, ensures complete removal, and thereafter the lenticular capsule is removed. In this case, we demonstrate lensectomy through a pars plana approach using the glued IOL technique. Conjunctival peritomy and cautery is done at 3 and 9 o'clock position. Rectangular scleral flaps of 2.5 mm wide are fashioned. A pars plana infusion port is created from the limbus in the inferotemporal quadrant. Another pars plana port is created below the scleral flap at 3 o'clock position. Lensectomy is done using aspiration mode in the vitrector followed by capsulectomy and anterior vitrectomy. This pars plana approach is also preferred if the lens has impending posterior dislocation and cannot be approached through the limbal route, or if the patient has myopic retinal degeneration requiring endolaser photocoagulation intraoperatively under general anesthesia. Glued IOL is then implanted and the corneal tunnel is sutured. Post-operatively, there was a dramatic improvement of the vision from the pre-operative level with almost emetropia. This slide summarizes the various cases that have undergone lensectomy with anterior vitrectomy. There is a significant improvement in the vision from the pre-operative level, as can be seen here. Thus, this video highlights the various different techniques of lensectomy and anterior vitrectomy with its modification, thereby ensuring that the lens is completely removed such that the patient can then be rehabilitated either by spectacles, contact lenses or intraocular lens implantation, and help smooth sailing of the ship that is caught in the storm back to its port.